At this point, we will start the access phase of the procedure. I wanted to first review some of the preparations we make just before we gain transeptal access and begin the mapping and ablation portion of the procedure. First of all, our room is staffed by a number of colleagues, including several EP nurses. Dr. Aslam Khan will assist me in the procedure. He's one of our EP fellows. We have a team of anesthesiologists who work in our case, and the patient is given a moderate sedation, usually with propofol throughout the case. We do not typically use general anesthesia. We have placed intravenous catheters. You'll see them on the fluoro images subsequently. The catheters include a duodeca catheter, which is a 20-pole catheter, 10 poles located in the right atrium and 10 in the coronary sinus. That's used for recording, mapping, pacing, particularly CS pacing, and also allows us to hook those 20 poles up into a Booker box so we can do internal cardioversions as needed if the patient has recurrent AFib and we need to restore sinus rhythm. In addition, we put in a multi-purpose catheter just in case we have to do any specific mapping or pacing, particularly if the patient has atrial tachycardias or SVT that we need to clarify mechanism. There are two long sheaths that are placed, currently located up in the superior vena cava. These are deflectable sheaths that we use ultimately to gain double transeptal access. And lastly, there's an intracardiac ultrasound probe. This is a phased array probe, which we find exceedingly useful throughout the procedure. Some of the images we've just obtained will be shown to you momentarily. This will be the image we'll be using initially when we gain transeptal access, and you can see the fossa ovalis is present at about 11 o'clock on the thin wall portion of the intraatrial septum. You can see the right atrial cavity is to our upper left. The left atrial cavity occupies the bulk of the screen in the middle towards the bottom right. Not well seen, but you'll see in a moment, is the left atrial appendage at about 4 or 5 o'clock, and then at about 7 o'clock is the mitral annulus. And we'll just quickly move through some shots that we've taken earlier. Here's a, can you go back one? Here's a high-resolution image of the left atrial appendage. It's small, there's no clot seen. We typically will do intracardiac ultrasound in every patient to look at the left atrial appendage. In higher risk patients or when there's not been adequate anticoagulation, we will often perform transesophageal echo as well. And then we can measure and assess each of the pulmonary veins. Right now you see the right lower pulmonary vein, it's on the large size. And you can see that in the middle of the screen we can measure Doppler velocities in the vein there. And that's particularly useful if you're doing a redo case to make sure there's no pulmonary vein stenosis. We can look at the right upper pulmonary vein that's present at about 2 to 3 o'clock on this image, these still images. And again, Doppler velocities can be obtained. And in this case at the bottom at 5 to 6 o'clock you can see the left vein orifice. This patient appears to have a common vein, which was confirmed on the CT scan. And what remains to be determined is the common vein have enough depth that we can place mapping catheters and direct our ablation towards the common orifice. It appears so on this ultrasound image, and we'll be doing some confirmatory maneuvers momentarily. And we'll move on to the transeptal now. Understood. So we're taking a Brockenbrough needle and placing it through the dilator, which is inside the long sheath. Lights down, please. The Brockenbrough needle is being moved through the upper sheath. And you can see the stylet emerges outside the dilator, we pull the stylet back so it's just inside. Can we switch to the pressure screen on the board? Have a hemostat? Is there a hemostat? Each of the sheaths that will be entering the left atrium have been pre-treated with a higher concentration heparin solution. Basically, it's undiluted heparin diluted 1-to-1 with saline. We flush the dilator, the long sheaths, and the Brockenbrough needle out of the patient on a table prior to gaining venous access, so that these sheaths are coated with a heavy concentration of anticoagulant. We find that to be protective against early thrombus formation, which is the usual time thrombus forms on the left atrial catheters and sheaths. And we have demonstrated in controlled studies that that is an effective means to prevent any thrombus from forming. That is an alternative to fully anticoagulating the patient before you perform your transeptal, either by chronic anticoagulation with warfarin or by acute administration of IV heparin. The advantage to this approach is that it does prevent early thrombus formation but does not expose the patient to any risks of the acute anticoagulation during the transeptal process. I think either is a reasonable approach. This is the approach that our lab has chosen. It's also advantageous because we're doing 2 transeptals, so there's a little bit of time involved in that. Lights down, please. Okay, we're going to withdraw the long sheath from the superior vena cava down into the right atrium.
I believe you have tenting.
Okay, our sheath fell on its withdrawal, and it appears on the LAO view to have fallen into the proper position onto the fossa. We'll advance it slightly until we feel some resistance, and now we're going to verify the fossa position on the ultrasound image, which you can see. This is a critical part of the procedure to make sure your transeptal is being performed at the right position, especially in patients who have altered anatomy or small fossa. This is very useful. Okay. Hold this. Hold this. Okay, now we can see that the fossa is nicely tented and gives us confidence in moving forward with the transeptal. Needle's advanced, and we enter the left atrium. That becomes evident on the pressure tracing as well. Now slide the dilator over the needle into the body of the left atrial cavity. You can see the sheath is kept oriented posteriorly. Can we get lights up, please? Okay, flush. And now we'll see bubbles appear on the ultrasound image as we flush into the left atrium. So we know we're in the cavity. And we'll go back on pressure. And now we'll move the sheath over the dilator. You can also see in this image that we have placed an esophageal probe, which is a temperature probe, allows us to monitor the temperature within the esophagus, and very importantly, allows us to know the anatomic position of the esophagus relative to our ablation target sites. So that's what you see posterior to the LA in front of the spine on this image. We're now withdrawing the dilator from the sheath. And we'll flush the sheath, and we can see bubbles in the left atrium, so one of our transeptals has been finished. We'll take the Brockenbrough into the second sheath. Lights down, please. And we'll again advance it to the tip of the sheath and dilator. Obviously, meticulous attention needs to be paid to any bubbles in the flushing systems. These long sheaths are hooked up to a continuous flush once they're in the left atrium that's continuously flushed with a heparinized saline solution. And there are bubbles in the left atrium. Can we start the heparin, please? And if we look at our LAO image, this is the start of the procedure. We have to our right the esophageal probe. You can see two sheaths in the left atrium. To the left of the sheaths, you see the echo probe and just a multi-purpose catheter that's sitting in the right atrium. And lastly, a duodeca probe. This is the 20 poles. The distal 10 poles are in the coronary sinus. The proximal 10 poles are in the right atrium. This is our typical setup for a primary pulmonary vein ablation.